All right, Brian, should we get started? I'm showing 9 o'clock.
Absolutely.
All right. It's Anthony Williamson. I'd like to call our Georgia Department of Community Health Care Management Committee meeting to order for January 9th. We have a board meeting later this morning where we'll give an update. And I think we heard that Stuart was going to be traveling during this meeting. And so, Brian, thank you for helping us out with our agenda. We did think it would be good to still try to keep a meeting for January. If we look at our minutes of our last meeting, I think folks recall back in October, we had a really good in-depth presentation looking at some of our data warehousing, data analytics, a lot of the capabilities there. Daphne Keith, the executive director of the Office of Analytics, walked us through the new EASE system, which was extremely impressive in terms of the type of data and what we're able to do now with that new system, which had been planned for some time. And that was essentially the bulk of the presentation for our last meeting. So that is if everyone is okay with the minutes, we'll move. Anything else on that? I see the next item on the agenda, Brian, is review of past presentations. Anything else you want to speak to on that?
No, I think you covered what the past presentations were. Great. So thank you, sir.
All right. I think this morning we're going to hear about some new program opportunity in the areas of elder care with PACE. So our first item, and I should go back, I apologize. Before we get too far, I do want to check with our other board members on the committee. I think I see Cynthia Rucker, Shane Mobley in attendance. Are there any other board members on that we want to make sure we capture? Okay, those are the two that I see in the participant list. So with that, Brian, I can turn it over to you. And do you want to share with us a little more information about PACE?
Absolutely. So thank you. And thank you, board members, for talking to me today and having me here to talk a little bit about the PACE program. I am a longtime DCH employee, longtime state employee, 27 years now, and 15 of which are with the Department of Community Health in two different stints. I was here for a while, I left and then came back, and I've been here about 10 or 11 years. But I actually started 27 years ago as an age blind and disabled case manager at DeKalb County DFACS, just determining if people who were 65 and older, disabled, or blind were eligible for Medicaid, food stamps, TANF, back when food stamps were actually pieces of paper and not on an electronic card. And so I've always been involved with the elderly population in one facet or another here at DCH. For a long period of time, I was the guy who was over the home and community-based waivers, our 1915C waivers. So I particularly am pretty excited about the department introducing the program for all-inclusive care for the elderly, or PACE. It's something that is covered by a lot of states. A lot of states have PACE programs. It's kind of an innovative design, and it's very, very effective. So I just want to run you guys through a little bit of what PACE is and how it really works with care management, and then talk a little bit, then see if you guys have any questions about PACE, and then talk a little bit about how PACE is going to fit in to the larger long-term supports and services framework for providing care management for individuals that are elderly or disabled. So all of our presentations start with our mission, which you guys have probably seen a bunch of times, access affordable quality healthcare through planning, purchasing, and oversight. And then our own purpose, which is shaping a future for a healthy Georgia. So if we get into what is PACE, and I'm terrible, I'm gonna tell y'all this right from the start. I'm terrible about not following slides. I do my best, but I am incapable of reading from slides as opposed to just telling you what's going on. So what is PACE? PACE, if for a lack of a better way of saying it, is managed care program for the elderly. And the way that I have explained it to a lot of people, and it's not trying to be proprietary or anything else, but it's just, I have state health benefit plan insurance, and my insurance carrier is Kaiser. Now, if you have Kaiser, I like to think of Kaiser as the Walmart of health insurance, for a lack of a better way of putting it. You have to really go to the Kaiser centers to get your care. I know, because I live here in Atlanta, that my Kaiser centers are at North Lake, they're up in Gwinnett, there's one in South Fulton. If I need to go to urgent care, I go to the one up in Gwinnett. If I need hospitalization, because Kaiser doesn't have hospitals in the state, but they do have arrangements with DeKalb, what I think of as DeKalb Medical. It's now Emory. And then the Emory that's here right in town. They have relationships and admitting privileges at those hospitals. So if I would need ER care, I know that those are my outlets to get it. But everything I get from State Health Benefit Plan runs through Kaiser. PACE is the exact same thing. That's the best way to think about PACE. So we have Medicaid members, and they are serviced by a managed care program for them. It uses an interdisciplinary team. It pays for everything. The PACE Center will pay for all Medicare and Medicaid payments. So any services these folks need who elect to be in a PACE program, that PACE Center is responsible for paying for their care. The PACE organization provides care 24/7, 7 days a week, whether that care is at home, in the PACE Center, in a hospital, in a clinic. PACE coordinates that care and is responsible for paying for that care. So if we go to the next slide. So who's eligible for PACE? So PACE is, the people who are eligible for PACE are a very specific population. You have to be at least 55 years old. So even if you're younger and disabled, you cannot be eligible for PACE until you turn 55. You have to be able to safely live in the community. So the PACE centers are community-based. They are not an institution. So one of the big purposes and why PACE was developed was to keep elderly and disabled individuals in their communities longer and not in nursing homes or hospitals. So these centers, we have to do an assessment to see that the person would be able to safely live in the community. And sometimes in the waiver world, we do have assessments where we go, this person's condition is just such that they have to be hospitalized, hopefully for a little period of time, or a skilled nursing facility for rehab for a little period of time until we can get them back into the community for supports. It could be pressure sores. It could be a whole bunch of medications that are not interacting together. But so we do need to make sure that they are able to live safely in the community. They have to meet a nursing home level of care. So just being 60, I mean, I'm 54 now. I always forget how old I am. I'm 54 now. So just being 55 doesn't make you eligible for PACE. You also have to meet a nursing home level of care. And so a nursing home level of care means that you need a daily skilled intervention, or you have a deficit in your activities of daily living, usually 3 or more, that require assistance throughout the day. So it's not just every person who is over 60, 65. You do have to meet that nursing home level of care. There are plenty of 90-year-olds that don't meet a nursing home level of care because they aren't able to do everything on their own throughout a day. They don't have any ADL deficits. They don't need a skilled intervention. Also, the last point is you have to live in a PACE organization service center. So these PACE centers are not statewide. They are targeted to specific zip codes. And you have to be able to live within those zip codes. Your residence has to be within those zip codes. And that's important because a lot of the PACE members go back and forth to the PACE center on a regular basis where they have an adult day health center, or they have a clinic in that center that they need to see the person at. Their primary care physician is often in that clinic. So if they need to see their doctor, they're sitting right there in the clinic next to the adult day health center, and they can see that doctor every single day. So for that reason, they have to be in the service area. A good rule of thumb nationwide is that service area needs to be able to be no less than an hour from the site. So you can't have zip codes that are much farther than 45 minutes to an hour out. And that makes sense. We don't want people who are 70 or disabled sitting on a van every day coming back and forth to the PACE center. So who can be a PACE organization? Basically, it's anybody, nonprofit, private, public entity that they have to have the following though. They have to have a governing board that includes community representation for that service area. They have to have a physical site and a facility that is usually around 10,000 square feet that provides adult day health services. That defined area we talked about, they have to be able to provide all packages of services. They have to have safeguards against conflict of interest. So if this PACE center also had nursing facility, they owned a nursing facility, or if this PACE center also owned a home and community-based service center, they would have to make sure that they had safeguards to ensure that they weren't just feeding all of their own businesses for services. That member would have a freedom of choice around providers outside of the PACE network that they would want to go to if they elected to leave PACE. And then a big one is they have to demonstrate fiscal soundness. And this is a real hurdle point for a lot of providers. So the rates are really robust for PACE. We will pay a PMPM for members, a per member per month fee for members who enroll to be in PACE. And it's really robust. And then they get another PMPM from Medicare. So the PACE centers get a good amount of money for each member they have, but they are responsible for all services for that member. So you may get a $12,000 PMPM per month, but you have to think, I recently had an MRI because I have an irregular heartbeat, and they made me sit in that horrible tube and do the checking of your heart, and everything was fine. But that procedure at Emory cost $7,000. And I was shocked at what the sticker price of it was. And that was like the Kaiser rate. So you have to, as one of these PACE agencies, be able to absorb that cost. If you have a lot of members who come in who need surgeries, who have high prescriptions, who have a lot of therapies, you're going to be on the hook for that. We have heard nationwide that typically a PACE center doesn't become profitable until they have at least 100 to 150 members. So until they get that number of members, they tend to lose money. And the typical PACE organization only enrolls 3 to 5 to 10 really members per month. So you have a good year where you are losing money before you become a really profitable, well-humming PACE organization.
So for example, if one of the PACE members is hospitalized for whatever reason, let's say they have open heart surgery, the PACE center who receives those capitated payments is responsible for all of the bills associated with that episode of care, including the hospitalization, all the surgeons, et cetera, come out of that. And that's kind of how capitation works, right? You receive that capitated payment, and you have maybe some lower utilizers and occasional high utilizers, but hopefully the math all kind of works out, is sort of what you're describing.
100%. You got it 100% right. And not only will the PACE Center not bill us, I mean, they'll get their capitation for us, but they won't bill outside of their capitation to us, but they won't bill outside of their capitation to Medicare either. So they're on the hook for everything for that open heart surgery. And consider not just, like you said, not just the actual surgery, but when the individual goes home, if they need in-home home health aides, let's say they need grab bars for their shower, right? Because they're now, or a shower seat, because they're going to need some help with bathing, then they would be responsible for whatever durable medical equipment that individual needed to safely be taken care of at home. So everything, myself and Joe Hood, well, I'm pointing right here, Joe's not here, but Joe Hood were able to go to a PACE conference recently. And the good part about the PACE conference was, it was in California, it was in San Diego. We got to tour 4 PACE centers. We actually got to go see everything that was in these PACE centers. And I think every single PACE center had a durable medical equipment area where people could just go in and get durable medical equipment. They also had, most of them had glasses providers for eyeglasses that came in like once a week or a couple of times a month. Same thing with dental providers. They came in a couple of times a month and did cleanings and other things for members. So it really is everything. So there are some people who have to work within the PACE Center, and that's the PACE interdisciplinary team. And this is a requirement. So inside of that PACE Center, there has to be this team. There has to be a dietitian, a driver, home care liaison, nurse, OT, a center supervisor, personal care, therapist for physical therapists. Your primary care physician is there. Your recreational therapist is there, and a social worker. This is at a minimum what is required for your PACE center. So just to give you an example, when we were in San Diego, we walked in the front door of one of them that was actually not attached, but associated with one of their federally qualified health centers. And it had a little reception area. Behind the reception area was a pretty giant library and activity room with puzzles and games and movies. Behind that was the adult day health center that had all the tables and activities. But to the right were the primary care physicians. They had 5 primary care physicians in a clinic setting. To the left was OTPT speech therapist. Well, really OT and physical therapists. They didn't think they had access to a speech therapist, but they didn't come in. And they were all there doing therapy. Next to that was durable medical equipment. Then they had a salon. They had a hair salon actually within this PACE center, which was a selling point for them. And they did a hair salon 2 or 3 days a week. They had people come in and do it. They had a nail area for individuals that were diabetic that might need nail care. So it was everything right there. And then these folks, the dietitian, they all have kitchens as well that is run by a licensed dietitian that not only feeds folks who come in for the day for adult day health that might need breakfast or lunch, maybe they need a low sodium diet or whatever, but they also have home delivered meals that they then send to individuals' homes who don't come in for the day that can help with things like, cholesterol meals, like maybe low calorie meals, maybe low salt meals. And then it says driver, which was one of the things that Joe and I were taken aback by from our very first PACE Center visit was the number of vans the PACE centers have. Because they are not only responsible for driving all these members to and from the PACE centers, but they're also responsible for driving to deliver home delivered meals or medications, or if durable medical equipment needs to come to my house, they come with a walker or whatever. So all that goes into the individual's homes. So the next slide talks about what's covered. I don't think we need to go over this again, but we have been really trying to let people know it is everything. There is nothing that is not paid for out of PACE. And it's not really just the state plan services, because I'm a bit of a Medicaid wonk and nerdy. We have a state plan, and then we have waivered services, which are extras to the state plan. So if you're in PACE, you're responsible not only for state plan services, but you're responsible for all those extra services too. Things like personal support services and home delivery meals. And if you need an emergency response system, I've fallen and I can't get up. That's something the PACE Center provides.
So Brian, question on these services, for example, prescription drugs, et cetera. Do the patients who are enrolled, do they still have any co-payments or any responsibility for some of these services at all? Or once they're enrolled, they have no further out of pocket for any of the services provided?
Yeah, there's not a patient, that's a great question. There's not a patient liability or cost share that is associated with the PACE Center. So even those nominal co-pays we do for prescription drugs when you're enrolled in Medicaid, the 50 cents or the $1, we don't have those in the PACE service area. So if you are enrolled, you don't have those. You don't have a patient liability like you do in a nursing home or in the CCSP waiver, and you don't have the co-pays.
Okay, could we pause there? I just want to check for a minute to see if any of our board members also have any questions on some of the content so far.
Good morning, Mr. Brian. This is a great presentation. I want to say that, and it's so detailed. I did have one small question, and I definitely appreciate the fact that y'all have toured like the PACE centers. That's really great. How have they in other states avoided the duplication when dealing with Medicaid and Medicare when you are incorporated PACE?
That's a really good question. So it's one that in that same conference, there were actually breakouts about, it's funny you say that, there were breakouts about coordination of benefits between Medicare and Medicaid. There's a lot of, so and you guys know this, in our business, there's a lot of things that Medicare will pay for that we won't pay for, that we pay for. There may be Medicare rates that are greater than what the Medicaid rates are. So once it crosses over, there's nothing that's left over for us. The good part about PACE is you have a contract not only with the Department of Community Health. These folks are, and I think we'll get into this in just a sec. We're almost done with the presentation. That we get them by RFP. They're competitively bid for these areas to become PACE centers, and then they enter to a contract with Medicaid. But they also enter into a contract with Medicare. And Medicare says, hey, we're going to give you this amount of money. And then we say we're going to give you this amount of money. So it doesn't really, it actually removes some of that back and forth behind coordination of who pays for what and who authorizes what, because they're just reporting back to us what they have provided to the member in the form of encounters. Like we provided a hospital, like a surgery, and we provide these drugs so that we know for reporting what's going on. But it really does shift that emphasis onto the PACE Center for providing whatever the member needs, and then just utilizing like the block grant money to pay for it.
Thank you. This is a great program.
Yeah, hey, this is Shane Mobley. I want to ask a question because I'm actively in healthcare. What happens if there's an overutilization and this PACE center becomes underwater? Is there a mechanism for that if they say, wait a minute, we've got a much sicker population than what we had anticipated and we're no longer viable? Because in my experience, things go down and not go up, but salaries go up. So is there a mechanism for that?
So we will do similar to as we do with the CMOs, where we look at rates and reconcile rates based on what utilization is done in. That's where that encounter information comes back, where we say, okay, we're going to give you, and I can't remember what the number is, guys, so don't quote me on this, but I think our initial PMPMs for these members are like $6,000 or $7,000 a month. Between $6,000 and $7,000 is what Medicaid will pay out. And we get to that number from looking at similar situated people who are in nursing facilities and paying slightly less. So it's actually a cost savings for the state over the person being in a skilled nursing facility. But we do reconcile. So if you have a facility that is out there really burning through high cost members, but keeping them out of skilled nursing facilities, their capitation should go up to account for the additional services that they are putting out, as long as it remains under the AWOP, which was the amount that would otherwise been paid to the nursing facility. So there is that mechanism. Also, we have put into the RFP, which hasn't been released yet, but it's kind of in the final stages with DOAS, a pretty robust look into the fiscal soundness of these people who are going to be PACE centers. In California, and we're part of the National PACE Association now. We've talked to many states, and uniformly they all say the same thing. If you can get to 100 members, you'll be making money. You'll be fiscally sound. You'll be where you're not in trouble. But if you don't get to 100 members, then it's likely you're not going to survive. And then we would have to look at whether or not there would be a second PACE center in that area that could take over those folks' care, or one of the other services that are in the long-term supports and services section.
Yeah, I just know that, sometimes in California, they can be a little bit healthier, sometimes in the southern states, I think our food's a little better. So
Yeah.
we have a lot more cardiovascular issues in the South. But I'm just like I said, I don't know how you get to that 100 without going broke before you get to that 100.
So in the waiver world, this is it's also something that we see in the waiver world quite a bit, in the home and community-based waivers. And the good case management agencies, even the marginal case management agencies, because I don't think we have any bad case management agencies, they have really learned to look at their acuity mix and learned that, yeah, we can take on a really high acuity member, but we need to make sure we're taking on some medium acuity members too. And let me say this, I'm glad you said what you just said, because there's something else that is different about Medicare than Medicaid. In Medicare, you get paid way more for taking really, really high acuity members. So Medicaid, we just pay you one amount for your center by service area. But Medicare, you do an assessment on the person, and that assessment, the score of that assessment drives a multiplier, and that multiplier is by how much Medicare will pay you for that member. So if you're taking a lot of high acuity members for Medicare, you get way more money than if you're taking low acuity members. And again, that conference I went to, I sat in a thing with doctors where they were talking about how best to do an assessment to ensure that your acuity level is appropriate so you're getting the right amount of payment from Medicare. So there is that too.
Great questions. Great question.
Yeah, really good questions.
Thank you.
So I'm just going to run through. The next slide is just, again, talking about what we pay, which is everything. Then I want to talk a little bit in the next slide about like what we've done. So if we go past the assessment slide. So in 2024, the legislature did ask us to do a assessment of PACE for Georgia. And then what we did in response to that, which is on the next slide, is we had several meetings with the National PACE Association staff. We met with interested providers in this state and national providers. We met with North and South Carolina who have PACE centers. We reviewed estimates of potential members who could be served. Joe and I went to the national conference and toured PACE centers. I personally have spoken to the PACE Center in Mobile, as well as the PACE Center directors in Ohio, and I met some PACE Center directors in I can't remember, Virginia, I believe it is. And we've had a back and forth, and they've kind of done a virtual tour of some of their centers in Virginia as well. On the next slide, it just gives you, again, what we've talked about. The people that we initially got interested in were in Fulton, DeKalb, Bibb, and Chatham. We've had some additional interest, like in Gwinnett and other places since then. And it's important to note that these members do visit the center typically multiple times a week. We also we got with the PACE centers to do a viability check on the areas. And we talked to one national PACE providers. We've since talked to a couple other national PACE providers. So we've had good conversations with all these folks about whether or not they showed interest in Georgia, and there appears to be a good amount of interest. Then also, and this is kind of the final thing, in 2024, there was also House Bill 1078, this is on the next slide, which it was sponsored by Representative Jesse Petrie and carried by Senator Watson in the Senate. If Representative Petrie he has been around for a long time in our space, in the home and community-based services space. He was a alternate living services provider for many years before becoming a representative. So he is very attuned to PACE and kind of thinks this is a great idea as well. But they passed legislation that allows us to implement PACE in the state of Georgia as far as licensure. And this is on the next slide. So, and then on our last slide, if you keep going forward more, there was also a grant. Go up one more for me, Brittany, real quick. There was a grant that in the amended fiscal budget for 2024 for $2 million. And we gave three $500,000 grants to three nonprofit agencies that are looking to build up their centers in order to be able to bid for PACE for the RFP. These were all Georgia companies or agencies, and they were all nonprofits. They all got $500,000. Doesn't mean that they'll win the RFP by any means, but it was seed funding for things like buying a center if they needed to, or getting that development help in. You may find.
Brian, clarifying question, the prior slide where it was mentioning HB 1078 says currently awaiting the governor's signature.
It was signed. That's old. I should have fixed that. It was signed.
Okay,
So we're
so
good to move forward.
so approved to move forward, and that includes the 2 million in grant funding.
Yep, those grants have already been awarded.
Okay.
So they were awarded in July of last year, and those folks have already gotten, there were only three that applied and all three got the grant. And so that went out to those three providers at this point. And then finally, just kind of where we are is the final slide. We're in process of developing our program and policy. We have done a lot of work on development of the per diem rates. They're not final, but they are pretty close to final and final enough to put the estimates in the RFP. We have a SPA that is drafted. It is in queue with Lynette to be sent to CMS right now. We will have to send that SPA and get CMS to approve. It's a boilerplate template, though. I doubt there will be much back and forth between us and CMS on it. They may ask some questions about how we developed our rate, but otherwise, I think they're going to be good. We have to contract with each provider we pick out of our RFP. We have to do some eligibility work to be able to pay these providers out of our GAMIS system and get their encounter claims in. And that's that GAMIS work and the eligibility work. And then we're required to do ongoing performance improvement and quality oversight. So we will be leveraging our quality sections here, existing quality sections, to help us with that. We also have, in my section, we have 2 employees that have kind of been repurposed and will be working on PACE as we move forward. They're still doing their old job, but once we get through the PACE RFP process, they're going to be available to help with enrollment and questions and site visits. And that should be everything. I did want to talk just real briefly about how this fits into the larger, and this is the next agenda topic, how it fits into the larger LTSS framework. We talk a lot about care coordination.
Could you just pause right there just for a second? Then where we're at right now, just kind of going back to the prior slide, is getting the rates established, getting the policies established, filing the amendment to CMS, et cetera. So any thoughts on what timing might be for when we might see, enrollment beginning or kind of go live? Or you mentioned grants given to 3 organizations. Are they pursuing these 10,000 square foot facilities? I mean, what, can you talk a little more about kind of what you see as next steps?
Yeah, that's a great question. So, next steps really are getting CMS to approve the state plan amendment. We should have that submission done this month. And getting the RFP posted, which I know Joe wants to happen this month as well, and hopefully it will. And then getting those two things graded and having those folks awarded. If we get the PACE centers awarded from the RFP, then it usually takes them about a year to build up and get ready for enrollment. 6 months to a year, depending on if they already have a facility. Some of the folks we anticipate on bidding already have a facility. They may already be a big nursing home provider, or they may have a space. We know they have a space that they're working on right now. So my guess would be that early in 2026, like around this time next year, we'll be talking about when the first enrollees start going into the centers. We're hoping that, well, it'll probably be more like June if I'm being realistic, because it usually takes 6 months to a year from the RFP award for them to get up and ready to go.
Okay. All right. Very helpful.
We did find out when we were in California from because there were people from every state there at the PACE, everybody who does PACE, which is like 30 of the states, I think now have PACE centers. We did find that the number one place that is bought by PACE centers are Rite Aids and drugstores that have gone out of business. Something about the way they're configured, the water in there, it makes it real easy to switch them to PACE centers, which we were kind of fascinated by.
All right.
Any other questions?
Any other questions from our board members before? I think you were going to transition slightly to a different or related topic, but any other questions?
No, I'm good.
No questions for me.
Okay, Brian.
Thank you. So I just wanted to touch real quickly about the long-term care and support system. And you guys know this as board members, but we have, and I do approach things from an old eligibility brain, like how people become eligible for Medicaid. And in my head, there's really two routes for becoming eligible for Medicaid. There is family Medicaid, right, which is based on just your income and your family circumstances. Are you pregnant? Are you low income and do you have minor children? Do you have minor children in the home? Are you a foster care child? Those are all considered family Medicaid categories of aid. And they are all in the CMOs. And the CMOs are responsible for their care management. But then there's this other side of the house, which is the age blind and disabled house. And that consists of your supplemental security income individuals. Those are folks that are either 65 or disabled, and they didn't have an opportunity to put in enough quarters into Social Security to make more back from their Social Security payments than the federal benefit limit, that poverty level, 100% of poverty. So they get an SSI payment because we as the nation have decided everybody who's 65 or disabled and a citizen should at least have this much amount of money. And most states automatically give you Medicaid with those SSI payments. And then there's other people in that age blind and disabled bucket. Nursing home individuals, people in nursing homes, people who are in hospitals for more than 30 days, people who are in hospice, people who are in our home and community-based waivers, our Katie Beckett children that have severe disabilities. That's the age blind and disabled side of the house. We're doing a lot of work in the family Medicaid side of the house with our CMOs to beef up the care management, and you hear about that a lot. The other side of the house, you may get care management if you're in the waivers because you have a case manager, or if you're in a hospital through the hospital system. But a lot of members that are in that ABD section that are receiving SSI, they don't really get the care management. So PACE will just be another arena for the individuals who have a higher acuity and meet a higher level of care till we access a coordinated service that does provide, a dietitian and a case manager to really make sure that they are able to stay in the community. And one final thing I really try and hammer home with the PACE presentations are, who gets enrolled in PACE is completely at the discretion of the member. It's 100% driven by member choice. So a member chooses to go into PACE and they can choose to opt out of PACE at any time. And then we would disenroll them from PACE and put them back into the regular ABD category of aid where they started, or into a waiver if there was a slot in the waiver and they wanted to go there. So this is not something where we automatically enroll people or where we give a certain population. This is all driven by member choice. I think that's all I have today. I feel like I've talked way too much.
Yeah, well, I mean, it's been a very robust and thorough presentation. One, on that last comment you made, and maybe you heard this in the conference, of those members who select to go into PACE, is there any data yet from the other programs, 30 states, et cetera, on the percent who remain in PACE, or maybe they dip their toe in and opt out and want to go back to traditional?
Yeah, so the thing is, almost in every state, PACE is wildly successful. Like, the data shows that people stay in the community far longer who meet the level of care, who are associated with the PACE centers than folks who aren't associated with the PACE centers. I think it's 5 or 6 times longer. It's not just twice as long than the average person who's in the community who otherwise ends up in a hospital or a nursing facility. And there's very, very high satisfaction rates for members with who go into a PACE center. We actually have this in another one of our slides. I wish I had put it in now. Some satisfaction surveys from Rhode Island and Ohio and another state, and I can't remember, it may be there's only one PACE center in Mobile, Alabama, but I think that was the PACE center too. But they were like high 90 satisfaction numbers. They were really high satisfaction numbers for people who have been enrolled in PACE. And the PACE centers are really incentivized to keep people, right? Because they want to be over that 100 amount and get more and more people. So they tend to get creative with things like dentists and ophthalmologists. We went to one in Chula Vista when we were in California, and 95% of the individuals spoke Spanish. And 4 of the 5 doctors were Spanish speaking. And the local Catholic church had bought the building next door to the PACE Center. And so they had like a church right next door. So folks would just go back and forth from the church to the PACE Center. So they are really incentivized to make these places really positive for the members so they don't lose their population.
Very good, very good. Shane, Dr. Rucker, any further questions for Brian this morning?
No, it was excellent. I really appreciate it.
I agree. Very comprehensive, in-depth presentation. You can really tell your passion for this program, and it's just a worthy program. So no more questions for me.
Okay. Well, Brian, again, thank you for the in-depth presentation. It's been very educational for us. We'll give a brief update on it at our board meeting later this morning. And so with no further business, we will adjourn our Care Management Committee. Thank you.
Thank you.
Thank you.